Good afternoon, everyone, and welcome to the webinar. We're very excited today to launch our new series, In Control, which is empowering patients to take control of their heart failure. Today's webinar is the first of the 4 sessions that we will be hosting, and today is all about the basics of heart failure. As you know, Mended Hearts' mission is to inspire hope and improve the quality of life for heart patients and their families through ongoing peer-to-peer support, education, and advocacy. We're very excited to say that you can reach us on all the different platforms out there on social media. We have a new heart line at 1-844-HEART-87. And you can also find us on the internet at mendedhearts.org, mendedlittlehearts.org, and our new site, myheartvisit.org, where you can get a heart visit anytime. Today, we are going to start the webinar off by listening to the basics of heart failure by Michelle Gilbert. Michelle is with the Atlantic Health System in Morristown, New Jersey. I am Andrea Baer, the Executive Director here at Mended Hearts, and I will be the moderator. I am going to turn it over now to Michelle, and Michelle can lead us in this great discussion, and we will take questions and answers at the end. My name, again, is Andrea Baer, and I am going to introduce to you Michelle Gilbert, who is a nurse practitioner at the Heart Success Program at Chilton Medical Center in Pompton Plains, New Jersey. And Michelle, thank you so much for being here with us today, and I'm going to turn it over to you.
Well, thank you very much for the kind invitation to speak today. I am as you said, I'm a heart failure nurse practitioner. I see patients in the hospital, and as an outpatient practitioner, I've been taking care of heart failure patients for about 30 years now, both in small hospitals and large hospitals across the Eastern Seaboard. My background is all different phases of cardiology. I've worked as an open heart nurse. I've worked as a dialysis nurse. I've worked in the hospital. I've worked in home care. So I have a pretty varied background. I just want to make one little disclaimer, and that's during this presentation, I know you guys are going to have questions for me. I cannot discuss individual cases because I don't know you personally, so I can't give personal advice to people, and I cannot predict the future of healthcare in the United States. So please don't ask me those kinds of questions. During this session, I will be discussing the heart and how it works, just a little bit about that, what exactly heart failure is, what causes heart failure, how to care for yourself if you have heart failure, and how to prevent heart failure. So without further ado, the heart is located in the middle of the chest. It's a hollow muscular organ. It's behind the breastbone so that it's fairly well protected. It's about the size of an adult fist, and it weighs about 11 ounces. The job of the heart is to circulate blood throughout the body. It's really 2 pumps working side by side. I also teach college. I teach nurse practitioners. I teach nursing students, and I kind of teach them that the right side is a low pressure pump to pump to the lungs, blood to be oxygenated, and the left side is a high pressure pump that pumps oxygenated blood to all the tissues of the body. The heart and the circulatory system really are very busy. An average heart pumps 4,300 gallons of blood per day to deliver oxygen-rich blood and nutrients to every cell in the body. The heart also has an electrical system that keeps the heart chambers beating in rhythm so that blood is pumped through the body, and it also has plumbing. There are 2 major arteries that bring the heart its blood supply so it can work. And we'll be discussing this in a little bit more detail later on. Now, the heart also controls its rate and also your blood pressure and blood volume throughout the body. And this is controlled by some mechanisms that link to your nervous system in the body. And these are tied into your fight or flight mechanism, and that's mediated by adrenaline. I think everybody knows what that is, which speeds up your circulation, and that's your stress response. And I have a reason for talking about this that you'll understand a little bit later on, which increases your blood pressure and sends more blood to your muscles when you need it. And it also causes your body to hold on to salt and water. And then the other side of that response is your rest and digest reflex, which slows down the circulation and lowers the heart rate and increases blood flow to your stomach. That's your rest and digest reflex. And all day long, your nervous system and your heart are kind of talking to each other to kind of balance this reflex. And that's what happens in a normal person. So what exactly is heart failure? Well, heart failure is a condition that occurs when the heart muscle can't pump enough oxygen-rich blood to meet the body's demands. This happens when your heart is either too weak, and that happens when you have heart failure with reduced ejection fraction, or your heart is too stiff, and that's heart failure with preserved ejection fraction, to pump effectively. When that happens, fluid builds up in your body and causes pressure increased in your lungs and your body. The heart failure is a very challenging condition to treat, and it's also progressive. The heart gets weaker and weaker over time, even though you may not initially notice the signs of worsening disease. And I've had a lot of patients come to me and say, I didn't have anything wrong with me until I came to the hospital. I had a young man just a very few weeks ago come into the hospital. He thought he had a respiratory problem, and we actually over time took about 100 pounds of fluid off of this young man, and he didn't think there was anything wrong with him, but it happened so gradually over time that he wasn't aware that there was a problem. Heart failure is a very serious disease. Something like 6.5 million people in the United States have heart failure. There's over 350,000 deaths every year attributed to heart failure in the United States. 1 million hospitalizations caused by heart failure, 6 million hospital days, approximately 600,000 patients have advanced heart failure, estimated something like 10% of the population. So I will always have a job. I will always be busy. And again, heart failure consumes a lot of Medicare's money. It's the #1 reason why people over 65 are in the hospital in the United States. And again, it's a worldwide pandemic. And every time somebody is in the hospital with heart failure, it increases their risk for death. Every time you're hospitalized for heart failure, your heart is damaged, which contributes to your heart failure getting worse. So don't think if you have heart failure and you're hospitalized, we put you in the hospital, get rid of all that extra fluid, tune you up that you're as good as new when you go home. That is absolutely not true. You need to take care of yourself so that you don't have these exacerbations. Repeat hospitalizations for heart failure remain a very strong predictor of worsening disease, and they're a very strong predictor of death for heart failure hospitalizations. So what is it that causes heart failure? Well, I'm going to talk about these top 4 causes of heart failure because they're very prevalent. They happen very often in this country. And I am going to, diabetes is going to be an honorable mention a little bit later on in my talk. So coronary artery disease, untreated high blood pressure, abnormal heart rhythms, and valve disease. Congenital heart disease is a common cause of heart failure, but usually people with congenital heart disease know about it early on. Diabetes and obesity is a very large cause of heart failure in this country, as are infections of the heart is not as much a common cause. So what is coronary artery disease or coronary heart disease? Coronary heart disease is a disease in which waxy plaque builds up inside the heart arteries, or the blood vessels that bring blood to the heart. This happens over many years. What causes this? Smoking, high levels of cholesterol in the blood, high blood pressure, high levels of sugar in the blood caused by diabetes, and blood vessel inflammation. Other names for this are hardening of the artery, atherosclerosis, and coronary artery disease. So what happens is, as you get blockages or plaque formation inside the heart, this plaque can crack or break in an artery, and then you get a clot that forms, and then this plaque is rough, and so a clot forms behind it, and you could have a heart attack. And when it completely blocks, it causes death of the heart tissue. And the amount or degree of blockage and the time that this is clogged determines how large the infarct or heart attack or area of damage is. So what can be done about this? Well, oops, I'm sorry, I forgot about this slide. So there are gender differences in heart attacks. Men and women have different types of heart attacks, and their signs of having a heart attack are different. So it's important for you guys to know about this. Women have different signs that they're having heart problems. Women tend to have dizziness, cold sweats, shortness of breath, indigestion, unusual fatigue, and then sleeping problems. I've had women that have only had jaw pain or back pain or sweating. So you women out there, if you have any of these signs or symptoms, get yourself to a hospital. Do not drive yourself. Call 911 and get to a hospital. You know when something isn't right. Don't ignore your symptoms. I had a patient who waited a whole day having jaw pain because she thought it was a dental problem, and she had a very large heart attack and barely made it to the hospital before she had an event. Men tend to have shortness of breath, crushing chest pain or chest pressure, and discomfort in the upper body. And the reason the symptoms are so different is because women have smaller blood vessels, and they tend to have plaque or blockage in smaller blood vessels, where men tend to have plaque or blockage in larger blood vessels, and that's why their symptoms are so different. So getting on with my story, here are the treatments. There are non-surgical treatments. If the blood vessel is amenable to a non-surgical treatment, you could have like a stent. Or in some areas of the country, clot buster therapy, or where that should be started within 3 hours of onset of symptoms. So that's where a stent or balloon angioplasty can be done, where a wire is placed across where the blockage is, and then a balloon is inflated with a little wire cage that's then inflated to keep the blood vessel open. This is done in a sterile room called a cardiac catheterization lab, and then medication is required to keep the stents open afterwards. This is very important. You must take your medications following this procedure. Okay, so surgical treatment. This is coronary bypass surgery. So either arteries or veins are used to bypass the blocked blood vessels. And here's a diagram of what this looks like. Can you see my arrow when I move my arrow? Anybody? So hopefully you can. So this is a vein.
Yes, we can see it.
Okay, this is a vein graft over here on the left-hand side. So it's removed usually from the leg, and it's stitched. This is the aorta coming up from the heart, stitched to a blocked coronary artery. Over here, this is the right coronary artery. And over here, this is a artery called the internal mammary, and this is removed from inside of the chest wall, and it's kind of redeployed and, and removed, And this is stitched down to, this is the left anterior descending blood vessel, sort of on the front of the heart, and it's kind of redeployed to bypass a blocked artery on the right side. And which one is done kind of depends upon your anatomy, how big the blockage is, where the blockage is. If it's in the opening to a blood vessel, it's not so easy to stent, and sometimes you need to have bypasses done. Okay. Let's switch gears and talk about hypertension or high blood pressure. This is a silent killer. Blood pressure is the force of blood pushing outwards on the artery walls. High blood pressure means the pressure in your arteries is too high. The top number, or systolic pressure, is the pressure when the heart squeezes or beats. The bottom number, or diastolic, is the pressure when the heart rests. Optimal blood pressure should be less than 120 for the top number and less than 80 for the bottom number. The lower the blood pressure, the easier it is for your heart to move blood around your body. What I tell my patients is, as long as you're walking, talking, and peeing, I don't care how low your blood pressure is. I say it in a nicer way. As long as you're ambulating, cerebrating, and urinating, I don't care how low your blood pressure is. That's a little more elegant. But seriously, the lower your blood pressure is, the better. As long as you're not dizzy and your blood work is okay and you're feeling okay, it's okay to have low blood pressure. It's actually better, especially if you have heart failure. I really encourage my patients who have heart problems to buy a blood pressure machine and check their blood pressure. It's very good to be involved in your heart care, and it's good to know what your blood pressure is. This is the correct way to check your blood pressure. You should be seated with your back straight and your arms supported at the level of your heart. Rest for at least 5 minutes before taking your blood pressure. The cuff should cover about 80% of your upper arm. Use an average of 2 or more readings on at least 2 occasions, and don't get excited if it's too high or too low. Wait for a few minutes and recheck it. Okay. Another thing that can cause heart problems is having too fast rhythms or too slow rhythms, or something like atrial fibrillation. I've had many patients who go into rapid AFib, don't know it, and they come to the hospital with something called tachycardia-mediated heart failure. We get them back into regular rhythm, slow them down, put them on a blood thinner because they're at high risk for having a stroke when this happens. And a lot of times their hearts get better. And again, this is an electrical system problem. Remember, we talked about the electrical system earlier in my talk. Okay, so if we can get them back into regular rhythm, we do lots of times, but sometimes all we can do is slow that person down. The most important thing is to slow patients down and get their heart rates down to a slower rhythm, because the heart gets its oxygen during the resting phase. So it's not good for the heart to go very fast, because then the heart is deprived of oxygen. Valve disease is another common cause of heart failure. So this heart on the right, and again, we're looking at the heart kind of sideways, so I'm going to point. So the heart has 4 chambers. These are the upper chambers over here where I'm pointing, and this is kind of like the profile. So you're looking at the pumping chamber here, and this is blood squirting backwards through an incompetent valve from the pumping chamber back into the left atrium. And you can see why this would be wasted motion. So this is what we call mitral regurgitation. So all of this kind of turquoise and yellow is blood coming backwards through the valve. Okay. On the right side over here is aortic stenosis. And this happens as we get older. You have calcium building up on the valves. And all of all of these little nodules here, or little bumps, is calcium building up on the valve. And as calcium builds up on the valve, it keeps the leaflets of the valve from opening all the way. And when that happens, blood can't get through. And high pressure builds up inside the heart and causes heart failure. And you can see there's also calcium building up on the leaflets of this valve. So this is, again, the mitral valve. And this is another problem that can cause heart failure. This is called bicuspid aortic stenosis. It's one of the most common congenital defects. Instead of this valve having 3 normal leaflets, these 2 leaflets are fused. And what happens is, because there's a lot of turbulence in this valve, you get early calcification in this valve. So valve disease can cause heart failure as well. So what exactly happens that causes heart failure? Well, there's a problem: a heart attack, high blood pressure, diabetes. Sometimes after a pregnancy, a woman can develop heart failure. After COVID-19, we saw many people develop heart failure. A virus, alcohol can cause, alcoholism can cause heart failure. Whatever causes the problem, no matter what it is, the body responds exactly the same way. There's decreased pumping action for whatever reason, and the body does exactly the same thing. It sees decreased pumping action, and it starts to put out adrenaline and other detrimental hormones. And because of that decreased pumping action, the body tries to prop up the cardiac output and do things that it thinks are going to help, but in the long run, it makes the heart problems worse. The blood vessels constrict, making the heart work harder, and then the kidneys get into the action, and they tell the body to hold on to salt and water. And this leads to fluid retention, causing swelling and shortness of breath. This also increases the workload on the heart, and because of all that swelling and all that extra fluid, there's decreased cardiac output, and because of all that extra adrenaline pushing more fluid back to the heart, there's more workload on the heart and worsening cardiac output, and this in turn causes decreased pumping. Because of the decreased pumping, we get increased adrenaline and other detrimental hormones, and we start to get inflammation and other problems as a result of this, and all of this starts to cause the heart failure symptoms we see in people. And you can see where I'm going with this. This is a downward spiral that just keeps going and going and going and going and going. So the good news is, with the right treatments and medications, we can stop this problem in its tracks. But it has to be discovered and it has to be treated. And I'm going to talk about how to treat this in just a moment. So how do we diagnose this? Well, we use x-rays, we use EKGs, we take a good history. So a healthcare professional will sit down with you and find out what's been going on, what your symptoms are, what your history is, what's been done in the past. We do lots of lab tests. We may do an echocardiogram, one of our most powerful tests that we do, both to diagnose heart failure and also to follow over time what's going on with you. We may do other tests like CTs and MRIs. Very, very helpful in knowing what's going on with the heart muscle, or coronary angiograms and other tests like that. So what are the symptoms of heart failure? Tiredness and fatigue, trouble breathing. I'll talk about this a little more in just a second. Weight gain, swelling of the hands and the feet, nausea, loss of appetite because there's fluid in the abdomen, rapid heart rate, and lightheadedness or confusion. So more specifically, shortness of breath with usual activity. So something that you usually do every day all of a sudden is making you feel short of breath. Trouble sleeping and inability to lay flat. The other word for this is orthopnea, is the medical name for this. And waking up in the middle of the night short of breath. All of a sudden you wake up from sleep and you have to sit on the side of the bed or blow a fan in your face, or you have breath. That is a hallmark sign that something is wrong. If you wake up in the middle of the night and you have to sit up to breathe, that is a sign that you need to either call somebody and get to the hospital, or you need to call your health care provider. Something is wrong. Swelling of your hands and or feet or legs. A dry, hacking cough that doesn't go away and is particularly worse when you lie down. A weight gain of 2 pounds in a day or 5 pounds in a week. That is a sign that you're holding on to fluid. 2 pounds is a quart of water, making you feel more short of breath. You might not feel it when it's a quart of water, but a quart and a quart and a quart is going to get you into trouble. Increasing tiredness and fatigue. That's a sign that things are going south. Okay. Some of the ways that we describe patients with heart failure is the New York Heart Association classification. So, class 1 heart failure patients have no symptoms of heart failure. And the way I describe this when I'm teaching it to nurses is a class 1 heart failure patient can run up a flight of stairs and they have no shortness of breath. A class 2 heart failure patient has slight limitations of physical activity. They're comfortable at rest, and ordinary activity might make them feel a little tired or short of breath. So that class 2 patient can run up that flight of stairs. They might be a little short of breath at the top of the flight of stairs, but they can keep on going. A class 3 patient has significant limitations of physical activity. Less than ordinary activities result in feeling tired and short of breath. So to get up that flight of stairs, that class 3 patient might get up 5 or 6 stairs and they're going to have to stop, catch their breath. They can go up 5 or 6 more stairs, stop, catch their breath. They can get up that flight of stairs, but it's going to take them some time and they're going to be pooped at the top of the stairs. A class 4 patient, no stairs. They're short of breath, sitting and talking to you. They are unable to carry out any physical activity without discomfort, and they are tired and short of breath, even at rest. Here's another way that we talk about heart failure patients, and I'm not going to go through this whole long list, but you may hear this described. This is the 2013 ACCF, American College of Cardiology, American Heart Association Guidelines, and this is kind of our Bible for how we manage heart failure patients, and it talks about stages. So stage A patients are at risk for heart failure without structural disease, and it talks about how we prevent heart failure. Stage B heart failure patients have structural disease, but they don't have signs or symptoms of heart failure yet. So this might be somebody who has an MI, but no symptoms of heart failure, or they may have valve disease, but no symptoms. Stage C patients have had an exacerbation of heart failure, and we do things to prevent them from getting worse or having problems. And our stage D patients are our refractory heart failure patients. These are people that have marked symptoms of heart failure at rest, and they have recurrent hospitalizations despite everything we can do to manage their symptoms. So how do we manage heart failure patients? We encourage them to exercise and increase their daily activity. Somewhere along the line, a lot of people with heart failure get the idea that they need to take it easy. Nothing could be further from the truth. Activity is good for you. Keep busy, keep active. It's good for your heart. Improve your diet and take your medications exactly the way we prescribe them. I'm going to talk about this a whole lot more. So what are the cornerstones of therapy for heart failure with reduced ejection fraction? So medications called angiotensin converting enzyme inhibitors, or ACE inhibitors, or angiotensin receptor blockers. So the angiotensin converting enzyme inhibitors are the ones that end in pril. Captopril, enalapril, lisinopril, any of those. The angiotensin receptor blockers are the sartans, losartan, valsartan, olmesartan, any of the sartans. And then sacubitril, valsartan, its other name, its brand name is Entresto. That's one of our new medications for heart failure and reduced ejection fraction, a really great new medication. Beta blockers for New York Heart Class 2 through 4, and you just heard me describe those classifications, or stages B, C, and D. That actually needs to be updated. I apologize for that. Water pills or diuretics to control fluid. Aldosterone receptor antagonists like spironolactone and eplerenone. For many classes of heart failure, we sometimes use digitalis for rate control and some forms of heart failure, and hydralazine and isosorbide for patients of African American descent, or for some people that can't take that first bullet point of medicines. And then guidelines like the ones I just described to tell us what to do for which patients. So here are my 4 pillars of cardiac self-management. And this is how I teach patients and how I teach nurses to teach patients. Oops. I don't know what this is. Hopefully nothing's going to go away. Okay, so mind your meds. Know your medications, and if you are just leaving the hospital, make sure you know exactly what you should be taking and should not be taking. Devise a schedule that you can live with. Sit down, make yourself a medication schedule that works for you. Tailor it around your meals. Make sure that you know what you're taking and that you know how to take it. Understand the actions and side effects of your medications and manage your adherence. Do not skip your medications. And if you find that you're missing your evening doses of your medications for some reason or another, figure out how to make that not happen. So I had a kid who was very nocturnal, and he was forever missing his midnight dose of a medication that he had to take. So I had him set an alarm on his iPhone so that he managed to remember to take his medication. So you can set reminders, you can set, you can do all kinds of things so that you remember to take your medication. So manage your adherence. It's incredibly important to take your medications the way they're designed for you to take them. If you find that you're having a problem, ask if there's a medication formulated so that you can take it once a day. But you need to take your medications the way they're designed to be taken. And make sure you can afford your medications. If you're having problems, talk to your provider. I had a patient come to me and tell me that they were having problems with one of their medications, and I found him a coupon that brought his copay down to $10. So there's lots of things that can be done, but you have to speak up. Know the red flags that you're getting into trouble. I'm going to talk about that in just a second. Review your pre-hospital symptoms, because those are the symptoms that are going to recur time and time again. And keep a symptom log. Write down your daily weights, because that keeps you honest. Oh, was I 150 or 151 yesterday? Was I 152 or 153? If you write your weights down, you're not going to mess up, and you have to commit to a number. It keeps you honest. Rehearse a response to changes in symptoms. So if I gain 2 pounds in a day, I'm going to call Dr. So-and-so. So you have to know what you're supposed to do. And I teach my patients to have a contingency plan. Okay, so if I'm going on vacation, if I gain 2 pounds in a day, I'm going to double up on my diuretics for 2 days. All right? I teach my patients, be good. If you can't be good, be consistent, because I'll work your diuretics around that. And if you can't be consistent, we have to have a contingency plan. And I have patients that I know are gonna misbehave. So I tell them, okay, so you know, if you go out and you eat something you shouldn't, double up on your diuretics the next day. Because I know stuff happens. See you in 7. Follow up with your healthcare providers within 1 to 2 weeks of discharge from the hospital. And make sure that you have good coordination of care. If you have a couple of doctors, make sure they talk to each other and get organized to get the most out of your doctor's visits. So show up to your doctor's visits with a list of questions and make sure your questions get answered. Manage your diet. there are 3 reasons why people wind up back in the hospital with heart failure. 50% of the reasons is not knowing how to take their meds and not knowing how to manage their diet. And the other third of the reason is not knowing the red flags that they're getting into hot water. So understand how to manage it. Understand what the salt is in your diet. Use the Weight Watchers approach. Most foods will fit. The one thing I tell patients is there's almost no Chinese food that fits in your diet. I'm very sorry, I love it too, but it's just so salty. Download an app if you have a smartphone. I really like MyFitnessPal. You can scan foods. You can do a running total for the day to help you figure out how much salt there is in your diet. You can, there's a whole bunch of different apps that will help you track the sodium in your diet. There is no such thing as low salt ham. Stay away from things like pickles and olives. They're very salty. But do know that you can have them once in a while if you eat a low sodium breakfast and you know you're going out to dinner. You can save the most of the sodium in your day and have it at dinner time. I'm down with that. And use your resources. One of the best things that I found out is that, if you live on the Eastern Seaboard, most ShopRite supermarkets have a registered dietitian. Get to know them. They will go shopping with you. You can make an appointment, go shopping with you, and go up and down the aisles and help you pick low sodium foods that fit in your diet that you like to eat. And they will help you do a meal plan. Most hospitals will allow you to call the dietary service and help you put together a meal plan. It's incredibly beneficial to tailor a diet that fits what you eat. This is the zone tool that I spoke about. This is on the back of every piece of heart failure literature that we hand out. So we want to stay in the green zone. The yellow zone means that you're having a symptom of heart failure, and the red zone means that you need to go to the hospital. Do not drive yourself. So what do you need to do to stay healthy? Well, I really do like AHA. Has a lot of great heart healthy literature. Be physically active, eat a heart healthy diet, maintain a healthy weight, manage your blood pressure. If you have diabetes, get it under control. Manage your cholesterol and stop smoking if you smoke. Why get active? Nearly 70% of Americans don't get the physical activity they need. Physical activity increases your length and quality of your life. 30 minutes a day is really what you need, at least 5 times a week. Even if you're overweight, physical activity can lengthen your life and improve the quality of your life, decrease your risk for stroke and heart disease. Why eat better? Because it's one of the best things you can do to affect the quality of your life. Control your cholesterol. If your cholesterol is 200 milligrams per deciliter or higher, you really need to take action. Your liver and your body cells make about 75% of the cholesterol in your body. The other 25% comes from your food. So you can have some effect over it. Heart healthy foods that are low in cholesterol, trans fat, and saturated fats are good for you. Eat a diet high in fiber, that will also help keep your cholesterol levels controlled. And make sure that you have a cholesterol screening so that you can stay current on your health checkups. And get your blood pressure under control. High blood pressure is the single most significant risk factor for heart disease. When your blood pressure stays within healthy ranges, you reduce the strain on your heart, your arteries, and kidneys, and that keeps you healthier longer. Take your medications as prescribed. Eat a heart-healthy diet and lower your sodium intake. Regular physical activity can also lower your blood pressure. Manage your stress, limit your alcohol, and avoid tobacco smoke. By the way, The Heart Failure Society recommendations for alcohol is 1 alcoholic beverage, and that's 1 ounce of hard liquor or a 6-ounce glass of wine or 1 can of beer for men. For women and 2 for men, which I think is highly unfair, but that's the party line. Get to a healthy weight. If you're overweight or obese, you can reduce your risk of heart disease by lowering your weight and keeping it off. Even losing as few as 5 to 10 pounds can reduce your blood pressure and reduce your risk for heart disease. And sometimes it's just a matter of balancing calories in with calories out and learning to plan accordingly. So if you're diabetic, what can you do to reduce your blood sugar? A lot of times carb counting can help in understanding where the carbohydrates come from in your diet. That really is an aha moment for a lot of diabetics that I've come across. And sometimes it's just making some really simple changes like decreasing the amount of simple sugars that are found in soda, candy, sugary desserts, and sometimes it's fruit intake. And moderate exercise can also help. And don't forget, you know, it's important to take your medications or your insulin if it's prescribed for you. And quit smoking. I cannot say it enough. Cigarette smokers have a higher risk of developing cardiovascular disease. If you smoke, quitting is the single best thing you can do for your health. It's one of our nation's top causes of early death, and your lungs can begin healing as soon as you quit. Quit 1 day at a time, 1 hour at a time, replace the cravings with healthier options. And even if you slip and you have a smoke, you haven't failed, just quit again. If you need support, visit the American Heart Association Quit Smoking website or NJ Quits. Talk to your healthcare provider or look for quit smoking programs. I really like AHA's Simple 7, Life Simple 7. Get active, control cholesterol, manage blood pressure, lose weight, eat better, control your blood sugar if you're diabetic, and stop smoking. Thank you so much. And again, I'd be glad to answer questions. Remember, I can't discuss individual cases or give personal advice. Thank you so much for listening.
Thank you so much. What great information. I already have a few questions, but I will remind everyone that you can place your questions in the chat box, and I will ask them out loud because I'm not able to unmute you guys. The first question that I have to kick off is, what role does stress play towards causing a heart attack? Is there data to support that stress is a risk factor?
Yes, stress is absolutely a risk factor. And it's very interesting when we look at the connection between stress and the development of heart disease, and particularly MIs. Men reported the stress leading up to an MI was work-related, whereas women reported the stress leading to a MI was family-related. Don't you think that's really interesting?
It is interesting. Yeah.
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 Yes, I mean, stress is a part of our life. It's undeniably there to stay. Especially for women, there is a type of cardiomyopathy that's called Takotsubo's cardiomyopathy. That is a broken heart syndrome. It is heart failure caused by too much adrenaline. The good thing about it is with treatment, it usually gets better. And it is literally caused by stress. I've seen it rarely in men, very commonly in women. So stress is definitely a factor. And, you know, there's not much that I can say except that we definitely need to manage the stress in our life. It is a factor. Yoga helps, meditation helps, walking helps. I think we have in my hospital and in my sister hospitals, we've been seeing a lot of people come in the last couple of months with stress-related illnesses for the pandemic. So I think we all have to do a good job of managing just the stress of social isolation and what's going on in the world.
Yeah, unfortunately, it's a very stressful time for everybody.
Yes.
I have a few more questions. The next question I have is, do the blood pressure normals change with age? And if so, how much?
That's really a terrific question. So the JNC8 guidelines came out about 2 years ago, and they were honestly very, very confusing. And then after they came out, there was further guidance that said that as people get older, you need to kind of soften the guidelines, because they found that as people get older, it was much harder to get the blood pressures down as low as the guidelines prescribed, and that we were seeing problems because of prescribing so much medication, that people were having hypotensive events. So as people get older, they're saying that within reason, blood pressure should be lowered. So, you know, it's a judgment call, and it's a softer number.
Great, thank you. Okay, the next question is, if your heart is stiff, why isn't the ejection fraction reduced?
Okay, so let me think of a good way to explain this. If you think about it, ejection fraction is the amount of blood that's pumped out of the heart with each squeeze. When the heart is dilated, holds more fluid, and so the ejection fraction is reduced because there's more blood sitting in the heart. So if my heart were a normal size, say, and it held 50 cc's, and with each squeeze, it goes out, I know that's not a word, 25 cc's, my ejection fraction would be 50%, right? 25 over 50, 50%. Does that make sense?
Yeah.
Okay. So if the second person, if your heart held 100 cc's and squeezed out 25 cc's, your ejection fraction would be 25 cc's. Right?
Yeah, 25%.
Right? 25 over 100. Okay. So your ejection fraction would be much worse than mine. Is that right?
Yes.
But your cardiac output is exactly the same as mine. It's the same 25 cc's. Do you understand?
Yeah.
Okay. So cardiac output is the important thing there. So ejection fraction is how much blood the heart puts out with each squeeze, but it has more to do with how big the heart is. Ejection fraction, so if the inner diameter of the heart is smaller, the ejection fraction is going to be normal. So when the heart is stiff, it's less compliant. What happens with heart failure with preserved ejection fraction, or HFpEF, is that the heart is stiff and it's hard for the heart to fill. The inner chamber is small, and so the cardiac output is reduced because it's hard to push blood into the heart. When there's high pressure, blood backs up into the upper chamber, the left atrium, and then back up into the lungs. And so that person goes into heart failure because that high pressure gets transmitted backwards into the lungs, and then the liquid part of the blood gets pushed into the air sacs in the lungs, especially when that person is volume overloaded. Does that make sense?
Yes. Yeah.
Okay.
It's very complicated, I know, and it's very complicated to even explain.
Yeah, so ejection fraction doesn't really mean that much in this circumstances. So even if your ejection fraction is normal, it doesn't really speak about your cardiac output. Your cardiac output is really the more important thing there.
Excellent. Thank you. All right. The next question is, does everyone get heart failure eventually with age?
Well, it's very common to have some arterial stiffness as you get older. You know, it's very common to get some what we call atherosclerosis, and it's not at all uncommon to get some valvular disease as you get older. You know, we looked at those at that calcification on the aorta. So it's not at all uncommon to see octogenarians and nonagenarians that have valvular disease and atherosclerosis. But a lot of people remain very healthy into old age, surprisingly. So the answer is most people, but you know, a lot of people remain surprisingly very healthy into old age.
Great, thank you. So at what point does a heart failure patient need to reduce liquid intake? Why do some have water limitations and others do not?
That's a terrific question. Thank you so much for asking that question. So the Heart Failure Society of America recommendation for that is fluid restrict patients that you cannot manage their fluid volume without fluid restricting them. So that means that you're giving them very large amounts of diuretics, and you know they're still fluid volume overloaded, or they're hyponatremic, meaning that their serum sodium on their blood test is low. So your body, the human body, very carefully manages the serum sodium, and when you lose control of the sodium, that's a sign that you're getting more advanced heart failure. So when your sodium starts to drop, that's a sign that you're getting more advanced heart failure, and that's a sign that you have to be very careful about your fluid intake. And usually when I do fluid restrict a patient, I ask them to stick to about 1.5 quarts of fluid. Fluid being anything that is liquid at room temperature a day. And I tell my patients, normally I don't fluid restrict patients within reason. I don't want them to drink gallons a day, but I tell them to drink if they're thirsty. I ask them not to push fluids, but I do ask them to not eat more than 2,000 milligrams of sodium a day. And as long as they're careful about how much salt they eat, I don't ordinarily fluid restrict patients, but those patients where they're fluid overloaded, I do fluid restrict. And the other caveat is if I had just put somebody in the hospital and I've had to give them lots and lots of IV diuretics for about a week after they've been home, I do ask them to be fluid restricted, because those people come home from the hospital very, very thirsty, because after you've gotten IV diuretics, your brain doesn't know that we just pulled a lot of fluid from your body. Your brain thinks something crazy just happened. And so until your thirst center resets, I ask people to be careful about how much they drink.
Excellent.
Okay.
Okay, so we're coming up on the hour, and we still have a few more questions, so I'm going to try to speed through them quickly. Okay. Are there some known medicines which may increase your blood pressure?
So there is a medication called Midodrine, but I try very hard not to give it to patients because it has some side effects that I don't like. It kind of squeezes down on the blood vessels to raise the blood pressure, and I'm trying to relax the blood vessels to lighten the load on the heart. So it's kind of a push me, pull you thing. So I avoid using it if I possibly can.
Got you. And then someone asks, how often should I follow up on a long-standing heart murmur?
It depends upon what's causing it.
Yeah, I was going to say it's probably something that is individual, whether it's annually or 6 months, but you should definitely be in care.
Whatever your doctor tells you to do.
And do whatever your doctor tells you to do. Right, absolutely. And then the last question that I have is, can you describe what happens with cardiac sarcoidosis?
Oh, cardiac sarcoidosis is that's not a disease I can, that's not a question I can answer in 2 minutes, okay. But hopefully you're being followed by a center. I definitely would make sure that you're being seen by an advanced heart failure center and getting very good follow-up, and that you've had a cardiac MRI and good follow-up. So, you know, sarcoidosis is a infiltrative disease and needs very close follow-up and monitoring.
Great. Thank you. Well, thank you so very much. That brings us to the end of our hour, and we appreciate you spending the hour with us and giving us such great information about the basics of heart failure. For everyone listening, this is just our first in our series of 4 webinars. This webinar, along with the PDF slides, will be up on our website in a couple of days. It usually takes a couple of days to get it edited and ready for release. Next week's webinar is on Thursday, again, at 3 o'clock, and we will be deep diving into cardiac or heart failure monitoring at home, why it's important, and all of the things you need to know about that. So we will see you next Thursday at 3 o'clock Eastern time, same time and same place. If you haven't registered, make sure you get over and register today. Thank you again so much, and you guys have a great day.